So today we'll discuss about the glomerulonephritis. So glomerulonephritis is nothing but the inflammation of the glomerulus and the small blood vessels. So the pathophysiology, see, you just briefly understand what the pathophysiology is. See, like due to any etiological factors, like it might be due to any like recurrent urinary tract infection or due to any renal calculi, might be because of any among the above said reasons, the release of antigenic substances into the circulation. So when an antigen is released into the circulation, for example, in case of urinary tract infection, it might be the bacteria which act as an antigen, or the virulence factors of the bacteria, which means the chemical substances which might release from the by the bacteria, or any of the substances which can act as antigen is released into the circulation. So when the when these antigens are released into circulation, there will be antibody formation. Obviously there will be antibody formation. So when there is an antigen released, there will be an antibody formed. So when the antigen as well as the antibodies combine, they will form the antigen antibody complexes, and the inflammatory responses takes place. So when there is an inflammatory responses takes place, the proliferation of the epithelial lining of the glomerulus will be affected. So it is nothing but when due to any of the above said etiological factors, the antigen antibody reactions takes place, and it will affect the lining of glomerulus. So when the lining of the glomerulus is affected, the infiltration of the glomerulus also affected, which means the normal patency of the glomerular membrane will be impacted. Then thickening of the glomerular filtration membrane takes place. So when there is a thickening of the glomerular membranes, it will lose the glomerular filtration membranes. What quality of the glomerular filtration membrane? It affects the glomerular filtration rate. Thus, it decreases the GFR, and it leads to retention of sodium as well as the water, which may leads to edema as well as hypertension. So you came to know that due to glomerulitis, the condition known as glomerulonephritis may leads to edema and hypertension. So this is the way how it leads to edema and hypertension. Next is, see how it is affected. See how it is affected. So inflammation of the glomerulus. It is mainly divided into primary as well as secondary. So here, see, the glomerulus, primary glomerulonephritis means it starts in the glomerula itself, whereas a secondary, the glomerulus are affected by systemic diseases, which we have already said, like in case of a complicated urinary tract infection, or might be because of any stent which we have kept inside the ureter, or due to any procedures like cystoscopy or ureteroscopy, or it might be because of diabetes mellitus. See, glomerular filtration membrane may be highly affected with the type 2 diabetes, type 1 or type 2 diabetes mellitus. Why? We have already said 180 is the plasma threshold or plasma threshold. So when the patient is severely keeping their blood glucose level more than 200, it will increase the pressure on the glomerular filtration membrane, and it leads to the disorder of the glomerular filtration. And it's again divided into acute as well as chronic. So the acute symptoms develop suddenly and which may resolve with the treatment, whereas a chronic we can treat it in an acute phase, and it also the disease will progressively develop, which is slowly and irreversible, which leads to failure of the kidneys. And what are the causes of acute glomerulonephritis? See, it is non-infectious, or it might be infectious. So we know that like rickets viruses, bacteria and parasites will affect, which is the infectious acute glomerulonephritis, or non-acute infectious non-acute non-infective acute glomerulonephritis is due to like sudden onset of any of the conditions, like in case of what retractable hypertension, or accelerated or idiopathic hypertension may leads to non-infectious acute glomerulonephritis. Clear? And what are the causes of chronic glomerulonephritis? See, the chronic glomerulonephritis is, while the acute phase might have developed, the acute phase would have started developing suddenly, but that is not the condition of chronic glomerulonephritis. It may takes time. So in the manner of this procedure of formation of glomerulonephritis, it would have started in any of the part of the body, like it might have started as a sore throat or a bacterial or infection which have affected your lungs or any other conditions, any other bodily conditions, which may further leads to the development of chronic glomerulonephritis and also polyarthritis, diabetic kidney diseases, like this focal segmental glomerulonephritis and Goodpasture syndrome. Okay, Goodpasture syndrome. So all these may leads to chronic glomerulonephritis. So what is Goodpasture syndrome?
Don't.
Hello.
I know, sir. I don't. Hello.
Yeah, what is Goodpasture syndrome?
Don't know.
Like what is Goodpasture syndrome?
Don't know, sir.
Okay, you are saying but don't know. So I was hearing something else. So this Goodpasture syndrome means it's just the disease which is affecting the kidney, or it may affect the lungs. See, the main distinguishing factor is that it is an autoimmune disease that affects the kidney as well as the lungs. That is, auto antibodies will be produced, which means it affects the filtration membrane. Okay. Then what are the symptoms of acute glomerulonephritis? What are the symptoms of acute glomerulonephritis? See, the symptoms may be start occur within 10 to 21 days after infection. So hematuria. See, all the symptoms which is affecting the renal system. Okay, genitourinary system will be more or less associated with oliguria, polyuria, hematuria, decreased GFR, hypertension, edema because of the fluid retention, ascites, or and the peritoneal cavity, fluid retention in the lung, which is known as pleural effusion. Okay, so how will you manage it? We'll go for what immune complexes proliferations and tests. So and what in case of chronic glomerulonephritis? See, the difference is that in acute phase it will be sudden onset. Okay, but in case of chronic phase, it will be slow and irreversible. Man, see, you just see the fatigue. So the patient will be feeling always fatigue in nature, and there will be gradual proteinuria. When there is when there is protein excretion from the body, it may leads to weight loss. And when there is an weight loss, and in order to what compensate that, body will be retaining the fluid. And also in conditions of decreased GFR, when there is decreased GFR, the water will be retained in the body, which leads to generalized edema. Generalized edema is known as anasarca. And due to what chemical responses in the body, when the creatinine level is increased in the body, which leads to visual disturbances, and it may affect the entire nervous system also. Okay. Why anemia? Like why anemia? Like,
Why anemia means
yeah, why
it
why
affects.
anemia is no,
Mm,
it affects
it affects. It affects the blood filtration, right?
it
Iron.
affects the kidneys.
Mhm.
What? It affects the kidneys erythropoietic functions.
And are
Okay. Like it is not iron, it is iron. R is silent there.
iron. Okay. I
And what will you pronounce ISLAND?
island.
Pardon, pardon.
Island.
Okay, so S is silent there. This is the same, while it is not iron, it is iron. R is silent there.
Okay. First one.
Yeah, is it for the first time you're hearing? So
Yes.
just see,
Yes.
don't
Yes.
believe me. Yeah, don't believe me. Then just use the Google, change it into the British pronunciation and check it by yourself. Okay.
Okay.
See, why I said that? See, many of the North Indian students are saying so. So I thought you are from South India, right?
Yes. Yes.
And even South Indians are saying so. Okay.
Yeah. We
So
used
what
to
are the
say.
clean? What? What?
No. No. Here we all used to say iron only, not iron.
No, that is incorrect.
Okay.
Next, the clinical manifestations. Clinical manifestations of
Okay.
So the clinical manifestations of flank pain will be the foamy or frothy urine will be the cola colored urine, diluted iced tea color urine. So why we have already said if there is infection, there will be frothy urine. So that's why it's a cola colored frothy urine. Hematuria, oliguria, dysuria, fatigues due to anemia as well as kidney failure. Hypertension, why? Because of fluid restriction. So edema will be it will be pitting edema. Okay. In case of fluid restriction, it will be pitting edema. Next one. So what is the difference between hematuria in conditions like hematuria? It is again divided into glomerular hematuria as well as non-glomerular hematuria. So when the glomerular filtration membrane is affected, there will be hematuria. Okay. So the other points are regarding the non-glomerular membranous problems, which means glomerular means it's completely affected the glomerular nephritis, or it has completely affected the glomerular filtration membrane. Whereas non-glomerular non-glomerular related hematuria is the disease conditions apart from the glomerular filtration membrane, which means it might be because of a problem with the entire kidney or with the ureters or with the bladder or with other disease conditions. Like when we focus on the kidneys, it might not be because of glomerular nephritis, but it might be because of any renal mass, which is a cancerous growth, or due to any pyelonephritis, then papillary necrosis, polycystic kidney diseases, which may finally leads to CKDs, then arteriovenous, it's AV malformations. Then when we come to ureters, mainly the thing is cancer, strictures, polyps, and urolithiasis. So bladder also same conditions. Cystitis and malignancy, cancerous growth. So other conditions like in case of benign prostate hyperplasia, see, usually the BPH is not suggestive of any clinical manifestations like hematuria, but in extreme cases, in rare cases, these benign prostate hyperplasia may compress the entire urethra and may leads to bleeding and prostate cancers and pseudohematuria. Okay, so these were the hematuria distinguishing factors of glomerulus as well as non-glomerulus conditions. So then complications. So what are the complications of acute glomerulonephritis? First one is acute as well as chronic renal failure. It may develop into a chronic renal failure. Nephrotic syndrome will be there. Hypertension will be there. See why electrolyte imbalance? Because of fluid and electrolyte excretion. So there will be electrolyte imbalance. It may lead to hypernatremia. It's not hypernatremia. And pulmonary edema due to fluid, excessive fluid in the body. So when there is pulmonary edema, it obviously leads to congestive heart failure because of fluid overload. Then urine analysis, we have already said proteinuria will be there, hematuria will be there. So how will you diagnose it? So we under the guidance of ultrasound, we'll take the through the needle biopsy, we'll take the kidneys biopsy and we'll analyze that. Then what is the management of this? So we'll symptomatically manage it. If it is glomerulonephritis, if it is an infectious condition, we'll manage with antibiotics. So we'll go with higher dose antibiotics like piperacin and tazobactam. Then if it is not managing of or the edema is not subsiding with the use of Lasix and the BP is not in control, we'll go with dialysis. Then we'll go with the medications like antihypertensive medications and diuretics, like mainly loop diuretics. So why we are giving immunosuppressants? So it to prevent the antigen antibody reaction. So methylprednisolone is the first drug of choice which we are giving in case of glomerulonephritis. So nursing management. So first thing, monitor the fluid and electrolyte balance. Okay, so we have already discussed the fluid and electrolyte balance. So I know you will be very thorough and clear about how the fluid and electrolyte balance is affecting the genitourinary system and it affects the entire bodily functions. And it due to the metabolic rate reduction, you have to check for the TSH level as well. Then pulmonary function to assess the pulmonary edema. Infection you have to prevent, and skincare and supportive therapies. So next condition is bladder. So bladder cancer. So this is a normal, this is a normal bladder. So this is a bladder tumor. Okay. So this portion is trigon. So you know the normal anatomy is also. So this is the growth bladder tumor. So what are the causes of bladder tumor? First one's arsenic in water. So when the water is infested with or infected with arsenicum. Then genetics, medications, and lifestyle. Okay. So what are the main, this is important, like please note this. points, 8 symptoms of bladder cancer, the main 8 symptoms of bladder cancer. So when there is a blood cancer, bladder cancer, there is gonna bleeding. Okay. Why? Because it's an abnormal growth in there, and these growth may rupture. Okay, so there will be pink or red color or color color, mainly pink and red color due to bleeding. So the your urination habits will be changed. Okay, so your peeing habits have changed. So what will be the, you will be going more often to, how will you pronounce this term? More, OFTEN?
Often,
Yeah, so often is,
often,
you can,
often.
yeah, you can pronounce this as often, which is a Britain pronunciation, and also you can pronounce that often, which is an American pronunciation. So more often you have to go to the bathroom. Why? Since your bladder is having an abnormal growth inside it. Like, once again, I'm asking,
The
what is the epithelium that is lining the urinary bladder?
transition.
Yeah, good. Transitional epithelium. Okay, so there will be pain. You will be experiencing pain, which means you won't be able to control your bladder. So that is the main change that you can feel in your bladder changes. And back pain, which might be radiating, especially in the one side, and low weight loss. So since in any condition, if you have a cancer, the significant clinical feature is that weight loss. And see the changes, how the bladder is affecting. See the bladder lining, the connective tissue. So stage 1, stage 2, stage 3, and stage 4. In stage 1, it is just inside the bladder lining. In the stage 2, it have affected the what? It have crossed the connective tissue and it have reached up to the muscles. In the third stage, it have reached up to the fat, and the fourth stage, it is a metastatic cancer, which means it could have come what, outside the bladder and affected the other portions. So this is TNM classification. T means tumors, N means lymph nodes, and M means metastasis. So TNM classification means how and in depth these tumors have been affected. Okay, this is TNM classification for. This is not these the TNM classification, and specifically for bladder cancer is not important, but yes, the TNM classification is important. Okay, so what is the treatment? First one is surgery. So we'll remove the bladder. Okay, bladder will be removed. That is one procedure. That's the first thing which you have to do. Why? Because when we have identified a cancer in some portion, we have to remove that portion. So next one is we go for chemotherapy. So chemotherapy as well as radiation therapy is the drug of choice for bladder cancer. And immunotherapy, what will we do in immunotherapy is that if the cancerous growth is very little in nature, we'll infiltrate the immunosuppressants, or like for example, if a cancer have been developed due to tuberculosis infection. Okay, when the patient is having a extra pulmonary tuberculosis and it had affected the bladder, what will we do is that we'll insert a catheter into the urinary bladder and we'll give the BCG infiltration. Okay, so we'll allow the patient to hold this BCG inside his bladder for half to 1 hour. Then after that, he is what suggested to pee. Okay, so that is that BCG therapy. And targeted drugs is it's a cancerous growth. For the cancerous growth and the genetic mutation, we'll give a targeted cell therapy. So this is modern radical cystectomy. So cystectomy is the removal of a bladder. So modern means new version. Radical cystectomy means we are not completely removing the bladder, but a portion of the bladder is removed. So radical cystectomy means removal of the bladder with its surrounding fats. So we won't give the fat, which why? Because there might be a chance for infiltration of the fat. Then we'll remove the not don't even remove the bladder, but also takes the prostate as well as the seminal vesicles, and in case of ureters as well as the fallopian tubules in case of female. Ureter will be also be removed. Then pelvic lymphadenopathy. So how more the lymph nodes taken, it's more better. Then so you know that there won't be any bladder since the bladder have been removed. urine from the kidney have to be stored in some other places. So for that, we'll go for urinary diversion. So what are the urinary diversions that we are taking? So first one is ileal conduit, urinary cutaneous reservoir, and ortho neobladder. So these are the conduit means we are artificially making a bladder inside the brain. See, this is an ileal conduit. So in this condition, what will you do is that both the ureters are connected into a specific part of the small intestine, and that portion is taken outside the body. Okay, so stomas or the reservoir, we'll make the other portion. Other method is we'll prepare an artificial reservoir in order to carry the bladder. Since the bladder is not in present, we'll remove the bladder. So we'll place another bladder in the position, which is called as about Indiana pouch as well as coach pouch. So and we'll take the stoma as a reservoir from this reservoir, and externally we'll take the urine. So this is like how it has been taken. Okay, the pouch is how it is made, how the neobladder or the orthopedic neobladders has been used. So you won't get any questions from here. And this also how the stomas have been checked, how it has been adopted. See how the coach pouch is used. No, you won't get questions from this. Next is what ureterostomy. So this is a normal procedure. This is normal ureterus as well as a bladder. So a stoma outside the body. So this is a pouch. How we are connecting. In this we'll collect the urine.
In this
Okay.
condition,
So
we urinate through stoma only, no?
yeah, definitely. It's because there won't be any sphincters, but it will be like we have how we have inserted a catheter inside bladder catheter. Okay, so nephrostomy. What is nephrostomy? See, simply when if the ureter have to also be removed, we'll just directly insert a catheter into the pelvis, renal pelvis, and drain the urine. Okay, so this is what we have said. This one is about how the bladder infiltrations are given. No need of this. What is BPH one?
BPH,
Yeah, it's benign
benign
prostate
prostate
hyperplasia.
hypertension.
So this is a
Benign.
normal. This is the normal prostate, and this is the enlarged prostate. Okay, so what is the cause? Aging is the main cause. Okay, then family histories, food which we intake, obesity, diabetes, risk factors of heart diseases, all these will aggregately increase the risk of BPH. So it's idiopathic endocrine changes. So no one will ask about the what are the causes, but what are the clinical features, of course, which means there will be dribbling of urine, difficulty in passing urine, straining while peeing, and the weak flow of the urine. Then what? Frequency at the night. The main thing, frequency at the night and urinary incontinence. The first drug of choice is what? What do we give? We'll give Urimax. That is tamsulosin. Just a smooth muscle relaxant. So when the smooth muscles are relaxed, we will be able
Anti.
to. So prostate is again divided into stage 1, stage 2, stage 3, and stage 4. In stage 1 and 2, we won't do anything. In case of stage 3 as well as stage 4, we'll go for surgery. And what is the surgery of this prostate enlargement?
Prostatectomy. Yeah,
Yeah, it
prostatectomy.
is known as transurethral resection of prostate, TURP. And how will be diagnosis? First thing first, history. We'll collect the history, like whether the patient is having frequency at the night, what urinary incontinence, what are the start and stop peeing status, and as a physical examination, when we do a per rectal examination, so we'll make the patient in a supine position with knees flexed. We'll do the per rectal examination. So when we do the per rectal examination, you can see a hard mass on the anterior portion of the rectum. Okay, that is the position of this gland. So you'll be feeling it as how you are touching on a wooden stick. Yeah, that much hard it would be. Okay, so the complications. See, when the obstruction of the urine is when the flow of the urine is obstructed, it leads to obstructive uropathy. Bladder will be hypertrophied. trabeculation will be there, diverticular. See the picture. Diverticulars, there is a chance of diverticular formation. Then trabeculations, which means increase in the rugates. Muscular hypertrophy will be there, and it also will leads to reflex in the ureter also. So the ureter also will be expanded and enlarged, which leads to which again affects the kidney as an hydronephrosis. So there is it's a high chance for developing secondary infections and urolithiasis. So symptoms which we said digital examination. So we'll scan the patient and identify the BPH, and we'll also check the reserve volume of the bladder after peeing. Okay, so then urine sample will be taken, urine flow rate. Then in blood test, prostate specific antigen. We'll check the prostate specific antigen. Okay. So in third as well as a post stage, we'll go for
In the
surgery.
prostate in this condition, sir, there is some effects on your what we can say sexual cycle also.
No, my dear. See, in case of prostate, in case of benign prostate hyperplasia, it won't affect the sexual functioning of the patient. Why? Because it has nothing to do with sexual functions. Okay, and the second thing is the age is the main reason. So it's in around above 60 people. So in Indian setup, I don't say globally, but Indian setup, yeah, after 60, sexual life is more sedentary in case of Indian male. But even though it won't affect the condition, but yeah, I could say that in case of stage 4 hypertension, benign prostate hyperplasia, as a complication may also arise. So there will be erectile dysfunction as well as ejection of semen will be complicated because of the compression of the bladder, the compression of the this gland.
So if we remove urinary bladder, also there is no effect on that.
We don't have anything to do with urinary bladder right at here. We are talking about benign prostate hyperplasia. It's the prostate gland which has been enlarged. Like we यार हमने वो छोड़ा वो bladder, we have completed the bladder. Now we are talking about the
Yeah, yeah.
benign prostate hyperplasia.
Benign prostate. Yes, prostate.
Yeah, okay. So this is a TURP procedure, TURP procedure, how the prostate is removed. Okay, so prostate, how the prostate is removed. So complications of the TURP is that immediate complication is bleeding. Yeah, next is capsular formation with fluid extravasation. So this is an important point which you have to check. See, the capsular perforation with fluid extravasation means during the procedure of TURP, it should be completed in a maximum stretch of 45 minutes. It should not go beyond the 45 minutes. The procedure should not go more than 45 minutes. So when we cross the limit of 45 minutes, see, this procedure have to be done with the presence of normal saline. We'll continuously irrigate the normal saline into the bladder and we'll continuously wash it out. Okay, so when the wheel continuously see, there is an since we are making cutting there will be bleeding. So in order to prevent the bleeding or to wash the bleeding, we'll use the normal saline. So when we are making cut and thus we are making an entry into this in venous system. So when we are making an entry into the venous system, there is a chance of these sodium chloride. The NS will be get into the venous system, which means it dilutes the vein, which leads to fluid extravasation and capsular formation. Okay. Next is TUR syndrome, and the late complications as the urethral strictus will be the bladder neck constrictions. Retrograde. What is retrograde ejaculation?
Retrograde ejaculation.
Yeah, the
Means
retrograde ejaculation is nothing but the semen will be ejaculated inside the bladder. Okay.
bladder.
Yeah, and importance will be the as a complication. Importance will be the incontinence will be the. So how we have to check for that? So continue after procedure. After this is important. Okay, after procedure for the 28 to 48 hours, the patient will be on sterile NS continuous drip. It will be 3-liter drip, and there is a 3-way catheter inserted. We will continuously irrigate the bladder in order to prevent the clot inside the bladder. Then what? Catheter patency should be checked. Bladder spasm have to be controlled. Pain management and straining while defecation should be avoided. And complications may arise like hematoma, continence, and infections. Okay. So we have completed the gastro and the genitourinary system. So do you have any doubt?
Benign